broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to everybody to the Population Health Research Network's webinar Wednesdays, which is kindly hosted by the ARDC. This is the third of our Wednesday lunchtime webinars by researchers who've used the PHRN infrastructure to assist them with their research. So this week, I'm delighted to introduce Dr. Monique Kilkenny, who's the head of the National Stroke Data Linkage Program, Monash University. And Monique's going to be talking on the topic of towards an integrated national data platform for stroke. Take questions at the end of Monique's presentation, and you can type your questions into the box on the right-hand side of your screen. And you can type the questions in at any time throughout the presentation, but we'll ask the questions at the end. So welcome, and over to you, Monique.
Thanks for that, Nicola, and I'm delighted to be here today speaking on my favourite topic, data linkage. So I'm going to talk about sort of our history over the last 10 years towards an integrated national data platform for stroke. So everyone on the line knows what data linkage is. It's joining two or more data sets together to produce a single data set. So, you know, with our data set, you can either link administrative data to registry data, or you can link administrative data to other administrative data, survey data to registry data, or trials data to registry data. So you can see in that icon there that we've done a lot of linkage of the registry to emergency data, national death data, medication data, doctor visits data, and aged care data. So you can see that linkage is joining two or more data sets together. So what's the value of linked data for quality of care? The best thing about linked data is that it's already available and it's cost effective. We don't have to sit there and worry about collecting this information again from participants. And we can also use the information that's collected from another data source to value add to routinely collected data. So we can look at things like thrombolysis, which is a drug that we use in stroke, clot busting drug, and we can look at that information and then link that to the administrative data to find out the mortality for you know, survival of these patients who receive thrombolysis, or we can look at whether they were treated on a stroke unit with data from the registry and link that back to the administrative data and see were these patients less likely to be readmitted after their stroke. We can also use data to validate quality. So we might use data sets to impute missing data that we have in one particular data source, or we might do some type of validation for like clinical coding to validate the codes that are in the registry compared to how it's coded in administrative data. We can also use linked data to do longitudinal analysis. So we can look at, as I just mentioned, for long-term survival, those patients who are treated in a stroke unit versus those patients who are not treated in a stroke unit. And with linked data, it supports various designs. We can look at trends over time. We can do cohort studies. We can do case control studies. We can do case cohort studies. With all these study designs, we can compare care received in hospitals, so whether they received thrombolysis or not. Or we can also use this data to do future sort of cost and economic evaluations. The other thing with linked data is that we can do research into rare events because we've got a big data set. We can have a look at rare events like, or small subpopulations like Aboriginal or those patients who require interpreter or English speaking background, which we may not have the same information in the trial data set. So this is just an example of a topical review that was published in Stroke this year, and that was by David Ang, one of my PhD students. And we were asked to look at what's the promise of this big data to improve the efficiency and comprehensive of stroke outcomes. I'm mainly today going to speak about my experience with linking the registry to other administrative data sets, but also big data can actually value add to clinical studies. It can value add to clinical studies because you don't have to follow up these patients over time. You can actually link the trial data to administrative data to maybe look at survival in 5 years' time after an intervention. So I think researchers in the future should really think about data linkage when they're planning their trials as well, because by planning this, you can actually look at, by planning this, we can actually minimise data waste and responder burden. Or we can also look at the reasons why maybe one of our clinical trials was a negative trial or a positive trial. We can explain the trial better by linking for extra information. So that was published in Stroke 219. So just a little bit about the Australian Stroke Clinical Registry. I'm not sure who's on the line and who's listening in at the moment, but it was established 10 years ago. And the information that we collect in the registry is any patients who are admitted with the diagnosis of acute stroke or transient ischemic attack. So that includes ischemic strokes as well as hemorrhagic strokes. The registry follows all the national clinical quality registry standards, has policies on data security and governance. With the registry, we use an opt-out approach, and we lose about 2.5% of registrants with the opt-out approach. And there's a waiver for deaths in hospital as well. We link annually the registry to the National Death Index to complement the registry. In 2015, the registry moved to an online integrated stroke data platform. So that is called the Australian Stroke Data Tool. So this tool not only collects information for the registry, but also collects information for information we collect in the clinical audits. Another great thing about the registry is that we collect information on stroke outcomes 90 to 180 days post-admission. And the things we collect at a 3 to 6 month follow-up, we find out where they're living, are they living alone, have they been readmitted, a self-reported readmission, whether they've had another stroke. We find out whether they're independent, independent 3 months after their stroke by the modified Rankin scale. And we also ask information about their quality of life using the EQ5D. And we ask them information, do they have problems, do they have any problems with mobility, do they have any problems with their self-care, anxiety, depression, pain, or usual activities. And as you see on the right-hand side of the screen here, the participants also rate their overall health. And so you can see that for the normative population, their rating is about 83, but for the Australian Stroke Clinical Registry registrants, it's about 70, so it's 13 points lower. So that's how they rate their own overall health. We also collect information for paediatrics, and we have an age-appropriate quality of life. So there's a couple of hospitals in Australia that collect information on paediatric strokes as well. As you can see, this registry has increased significantly over the last 10 years. So it's been mainly in the hospitals in the eastern border of Australia, and then mainly in Victoria and Queensland, which are the main states that have funded the registry. But good news is from 2020, majority of the states in Australia, except the Northern Territory, there has been a state-based funding for the registry to ensure that all hospitals in those states collect information via the registry on stroke and TIA. So you can see we have nearly 85,000 registrants up to 2019, and about nearly 40,000 of those have been followed up. As part of the registry, we do regular feedback. I won't go into a lot of detail here because it's not about data linkage. We do exports, we do externally facilitated quality improvement programs, and we also do research. This is an example of one of the process charts that we use as part of looking at performance between hospitals. So you can see down the bottom, that's the number of strokes that have been registered in that hospital, and you can see the middle line is the mean of the hospitals. So around about 70% of patients are discharged on antihypertensive medications in hospitals around Australia, and you can see some hospitals nearly do all their patients, and there's a few larger hospitals there's only about 40% of patients receive antihypertensives on discharge. So just another quick paper looking at follow-up. We looked at quality of life, and what we looked at there is patients we looked at those patients who required an interpreter versus those patients who didn't require an interpreter. And what we found that those patients who did require an interpreter tended to report more problems with usual activities, anxiety, depression, pain, discomforts, and self-care. And we also looked at the VAS scale, which is that scale we saw before, and those patients who required an interpreter were also more likely to report a lower health quality of life than those patients who didn't require an interpreter. So one of the first linkages that we've done with the registry was, the bread and butter, which is the most important one, was to find out, to make sure that we aren't following up people in the future of patients who have died. So each year we link the registry to the National Death Index. So some papers we've done in relation to that. We had a paper published in the Medical Journal of Australia where we looked at, how good is our matching with the National Death Index. And what we did was we linked those in-hospital deaths. We identified about 1,400 in both data sets, and we had very good sensitivity and specificity in the registry. So we can be really certain that the registry, when we record in-hospital death, we understand that it's a good collection of data in relation to deaths. Another paper looking at transient ischemic attack by Professor Monique Kilkenny, and what she looked at here was what's the survival after you've been treated in a stroke unit. So we compared those patients who were treated in a stroke unit versus those patients who weren't treated in a stroke unit, and what we found that those patients who were treated in a stroke unit had a 43% improved cumulative survival at 180 days after their stroke. So you can see that this is a good way of comparing survival and quality of care. And we showed that if you had better care by being treated in a stroke unit, you had also better survival. So another paper which was published in Neurology by Dr. Nadine Andrew, who's also a big leader in looking at data linkage, and Joseph King. And they published a paper looking at the prescription of antihypertensive medications discharged following stroke. And what they found that those patients who were discharged with appropriate medications, antihypertensives or blood pressure lowering, had actually had a 23% reduced hazard of cardiovascular death compared to those not discharged with these agents. So this is really good evidence saying the good care, the discharge care process in the hospital, you have better survival. So one other paper that we looked at was looking at comparing hospitals' risk-adjusted mortality, 30-day risk-adjusted mortality, comparing those hospitals around Australia. And what we found with this analysis, we found that stroke severity and history of previous stroke were very important variables for risk adjustment. So if you just use the hospital administrative data, which don't collect this information, the registry outperforms these models compared to using variables from the hospital administrative data only. This is one of my favourite papers that we've done with the registry data, and what it does is also another one using survival data or the death data. And in this graph you can see that survival is influenced by the number of processes of care received. So in the red dotted lines down here, you can see that's 0 quality of care. And in the orange line is the 3 quality indicators. So you can see here, the more care you receive, or the bundles of care you receive, the better the survival. We also in this paper looked at patients who were treated in a stroke unit, and we found that patients who were treated in a stroke unit had a 51% decreased risk mortality and also a 21 points better quality of life within 6 months than those patients who weren't treated in a stroke unit. So that's a great example of looking at using the deaths as well as follow-up data on quality of life. Another paper looking also the death data, what we found that those patients who were discharged in the weekend after stroke actually had poorer outcomes compared to those patients who were discharged on the weekday. So patients who were discharged on the weekend had a 22% greater hazard of 180-day mortality compared to patients discharged on a weekday. And you can also see that when we look at the quality of care, those patients who were discharged on the weekend were less likely to be treated in the stroke unit, were less likely to be discharged on antihypertensive medications and were less likely to be discharged on to the community care plan or receive a swallow screen assessment. So this is another example of linkage of the registry to the death data. So the next big project was linking not only the National Death Index, but to the admissions and emergency presentations data set. So the pilot study we did probably about 7 years ago and published it in 2015. What we did was we linked the registry for one hospital to the registry, and we had really good linkage, and that was done in Victoria. And we were able to look at readmissions after stroke, and it's really interesting. I repeated this study with nearly 15,000 patients, which we'll see later in the slides, and I actually got similar results, so that was quite reassuring. And what we found that those patients, readmissions influence, or the factors associated with readmissions, are those patients who are the big users of the hospital before their stroke, and also those patients who have more comorbidities, or which has been measured by the Charleston Comorbidity Index. And we also found those patients who had transient ischemic attack were also more likely to come back than those patients with stroke. So this Stroke 1-2 grant, which was the linkage of the 4 states around Australia, Professor Dominique Cadillac is the CAA on this grant, and she received an NHMRC partnership grant to look at linking the registry to the admissions and emergency data sets around Australia. So as you can see, each state has a different technique with the linkage, and each state was actually a little bit different in what patient identifiers they needed for the linkage as well. So this project, Stroke 1-2-3 Day Linkage Project, we're in this project, which we published the sort of the protocol in the Medical Journal of Australia. And what we managed to have linked, well, it was from 4 states: Queensland, New South Wales, Victoria, and Western Australia, with stroke or transient ischemic attack from 40 hospitals, and we had just over 15,000 patients. The beauty about this data set is we can actually look at what happened before their stroke. Were they admitted to hospital before their stroke? And did they have any comorbidities? And we could also look after the stroke, did they die? Were they readmitted for stroke or other conditions? And also what other comorbidities they had after their stroke, and any emergency presentations. So for the matching with the hospital administrative data sets, as you can see in this slide here, we had very good matching, 98% matching to the administrative data sets from those states and the registry. And you can see for Queensland and Victoria, we had a lower rate for the emergency linkage because a lot of strokes actually bypass emergency in Victoria and they go straight to admissions. So that explains the reason for the lower matching rates there. One of the first papers, this was completed by Nadine Andrews, honour student Chantel Chapman, and what she looked at here was patients treated in a stroke unit a greater risk of chest infection after stroke. So she looked at those patients who were treated and not treated in a stroke unit, and whether they had a chest infection after their stroke. And you can see some of the factors that were related to developing a chest infection after stroke. So patients who were admitted to an intensive care unit were 8 times more likely to develop a chest infection, and also those who had urinary tract infection were also more likely to develop chest infection. So you can see, you can look at lots of different factors using linked data. This is another project which was done by one of our PhD students who completed this year, Tash, and she looked at anxiety and depression after stroke. And what she found is those patients so IRIS-RAD is the socioeconomic position. So the lower category is more disadvantaged and the higher category is less disadvantaged. So patients in the lower category, so down here, the socioeconomic position were 59% more likely to report problems with anxiety and depression. So that's another example of using the comorbidities which were collected in admissions and emergency data set and looking at socioeconomic position, which is collected as part of the Australian Stroke Clinical Registry. This is one of the papers that's in newly accepted in stroke. And what we looked at here is the factors associated with 90-day readmissions. So using the registry and the mission emergency data set, we found that those patients who were high users, or the ones who've been admitted prior to stroke, were more likely that the patients to come back. And also, once again, those patients who had high number of comorbidities were also more likely to come back. So you can see here, patients with admissions 90 days prior to their index event were more likely, 85% more likely to be readmitted within 90 days from discharge from acute care. Okay, another project, just going through this quickly, done by one of my biomedical honours student, Lachlan Daly. He looked at antihypertensive prescriptions after stroke, and what he did there was look at what are the factors associated with a patient being discharged with medication after stroke. And what he found those that younger patients, so this is down here is the younger patients with fewer comorbidities, were less likely to be prescribed antihypertensive medication compared to older patients with comparable comorbidities. And over here you can see he also looked at other factors, and he found that those patients who actually had a history of hypertension were also more likely to be discharged antihypertensive medication, as well as those who have got diabetes, atrial fibrillation and myocardial infarction. This is another use of the linked data. This is by Elizabeth Lynch, and she's one of the postdocs that analyse this data with us. And what she wanted to find out is what are the factors associated with and outcomes those patients who are discharged inpatient rehab. And what she found with this paper was those patients who were discharged to rehab compared to home were also less likely to come back. So these patients discharged were less likely to be readmitted within 90 or 180 days compared to patients who were discharged home. This is another project which was done by my Health Information Manager student last year, Olivia Ryan. And what we wanted to do was we wanted to find out what the differences in coding. So what we did here is we compared the Australian Stroke Clinical Registry Clinical Diagnosis, or the reference standard, and we compared it with what was coded in the medical records. So you can see here, we're just showing in this slide a ischemic stroke. And there's, of the false negative records, a lot of them had unspecified stroke. So unspecified stroke in the coding is I-64. And I-64 won't allow us to delineate whether it's ischemic stroke or hemorrhagic stroke, whether it's a clot or a hemorrhage. So that was half of them were coded incorrectly. And so this is something we need to look at in the future to educate not only the coders, but clinicians, to ensure that it's stroke diagnosis documented correctly, as well as it's been coded correctly. This is another project that's done by my current PhD student, Lemmy, and using the same data set, he looked at the factors associated with arrival by ambulance. And what he found in this data set, there was 3 in 4 patients are arriving by ambulance, and those who arrive by ambulance are receiving the better care. So if you come by ambulance, you're 3 times more likely to receive the clot busting drug compared to not being come by ambulance. And what we also found in this analysis was that the frail older patients were also more likely to arrive by ambulance compared to younger patients with comparable frailty. So this is a project which is quite dear to my heart. We've just finished the analysis, so this is hot off the press. What we've done with this project is we've looked at linking the registry to the medications and doctor visits, or the PBS and MBS. So this is just some brief results looking at utilisation of secondary prevention medications after stroke. And so what we mean by utilisation here is, were these patients discharged, dispense 1 or more medications? So as you can see that we had just under 10,000 first ever strokes or transient ischemic attacks in this data set, and 95% were linked to the PBS and 97% were linked to the PBS and MBS. And you can see in this slide that 4 in 5 patients are being dispensed at least once after their stroke these important secondary prevention medications, including antihypertensive medications, antithrombotic medications, and lipid-lowering medications. Just another slide which use of the data. So in the past, we didn't have much information on medication usage. We really just had information on clinical trials, like a snapshot view at 3 months, 6 months, and so forth. So this is really important data. So what we found is that patients, 1 in 5 patients actually are discontinuing their secondary prevention medications after stroke. So, and what we mean by how we define discontinuation is for a period of within 1 year, they stop their medications for at least 90 days. So with antihypertensive medications, about 1 in 5 were discontinued. With antithrombotics, it was nearly 1 in 2. And with lipid lowering, it was 1 in 3 discontinued. And you can see down the slide, the median time to discontinuation. So it's about 6 months they're stopping their medications. So we need to do some type of intervention to stop this happening in the future. So as you can see, what we're trying to do is, for this whole study, is to try and capture the entire continuum of care. So we've linked the OSCAR to the admissions and emergency data set. We've linked the OSCAR to the Medicare. We've linked the OSCAR to the PBS. We've linked the OSCAR to AROC. We're currently linking OSCAR to the registry, and we've got a grant now to, done some grant applications to link the registry to POLA, which is the GP or primary care database. This is just a quick summary of the data sets and the process. So stroke 123, which is the main one I spoke about today, was the NHMRC grant, and you can see the states and years involved and who was the chief investigator, so Professor Cadillac here, and how we access the data from Monash. GP Stroke, Nadine, Andrew and myself have got funding from the Stroke Foundation to link the registry with PBS and MBS. Dominic also received funding from the Stroke Foundation to link the registry to ambulance. And Nadine, Andrew, myself and Joseph Kim have got an NHMRC grant to link the admissions emergency, PBS and MBS. And this will be analysed in the future to ensure we're still just waiting on the data linkage process for that. And we had some funding for AROC to link the registry to AROC, and that the analysis is in the process at the moment. So today, that was just a really fast snapshot view of what we're doing in stroke towards an integrated national data platform for stroke. So you can see that in 2009, we had a first patient registered, 12 hospitals contributed to OSCAR. Then we had a first linkage with the National Death Index in 2012. We did the pilot of 1 hospital. Then we got funding for stroke 1-2, and we did the final linkage for stroke 1-2-3 in 2017 of OSCAR with the hospital administrative data. We've also last year linked OSCAR with PBS and MBS, and this year linked OSCAR with ambulance data. And in the future, hopefully we'll get some information of what's happening in general practice as well. Just some quick tips if anyone's online. The most important thing with data linkage is to obtain advice from experts in the field. We've got a national stroke data linkage interest group. If anyone's interested on the line, they're more than welcome to contact me. The most important thing with all data linkage is plan your project. You need to obtain your relevant approvals from, from the data custodians and for ethics. And you also need to set up, secure data transfer and storage, and also make sure that you get the training to understand how to link the data sets and do the analysis, and and have fun along the way. As I mentioned before, that the National Data Linkages Group, what we're trying to do is build capacity. We want to build capacity from novice to expert, not only in analysis, but also to share expertise. There's a lot of people that have been part of the process, especially the Population Health Research Network. Felicity Flack really helped us with the cross-jurisdictional data process when we did that. It took us 4 years to receive that stroke 123 data. So this is the reason why we're only sort of publishing the papers at this stage. And the other great reason about this interest group, if you've got a barrier, you don't actually know what to do, there's always someone there who can help you. And we've got members from the group, and not only Monash researchers, but we've got heads from the state data linkage unit, heads from like Queensland, Trisha Johnson, and from Population Health Research Network, Leslie Flack. Phil Anderson from the Australian Institute of Health and Welfare also participates, and the Centre for Data Linkage, Victoria as well as other data linkage research experts like Vijay Zandaraga and Judy. So it's a great interest group. And just a few acknowledgements, and that's it. Thank you.
Okay, thank you so much, Monique. That was fantastic to hear the volume of work that you've been able to achieve. So just if anybody wants to ask any questions, you can type your question in the chat box, which is down on the right-hand side. But in the meantime, I think the Stroke Registry was a really early adopter of linked data, and that means I think you've really been trailblazers in this area, and hopefully you're paving the way to make things a bit easier for others. So just to summarise, perhaps Monique, you could tell us, what do you think the main benefits have been of going down this quite significant and extensive program of data linking with the Stroke Registry? I think the major benefits and outcomes.
I think the major benefit is, the cost is of the time of waiting for the data, but I think once you've got the data, it's just amazing what you can do with it. I mean, I think that example of the medications is phenomenal. I mean, we didn't know that before, because we had a snapshot view. We didn't know that people were stopping their medications at 6 months. So for me, that is you'd have to follow these people over time every month in order to get this information. And I think, be able to have snapshot view of understanding their adherence to medication at that level is fantastic. And that will lead us to developing interventions or alerts for general practitioners and pharmacists to ensure that these patients who are discharged for these medications are sent up some type of alert to make sure they continue with their medications. And I think also, I love the paper that we did in showing that, the better the care you receive in a hospital, the better the outcomes. And I think for me, that was fantastic. And that's a real draw card to say, it's really important that people go home with appropriate medications and go home with, a discharge care plan, because you're going to have better survival, and also you're going to report a better quality of life. So it does matter. And I think, linking a clinical quality registry to not only follow-up data on quality of life, but also things like survival, you can really encapsulate that, which you can't do that without doing a linkage.
Yeah, so you've got Polar, so the GP data is next on your list, and that's clearly quite an exciting step forward. Are there any other data collections that are on your wish list?
I'd like to, it's interesting, I want to go back to where I started. So I started in perinatal data. So I wouldn't mind looking at maternal, like hypertension. So I look at the perinatal data and look at, preeclampsia and risk of stroke. That's an idea. And also I've also worked in the cancer registry, so I wouldn't mind actually linking with the cancer registry and getting more information in that area, because the more I do research over the last 12 years, the more I realise how complex stroke is. And it's these patients are really frail and they're comorbid. It's not just stroke, they've got cardiovascular problems, and they've also got cancer problems. And we also would like to link to the intensive ICU registry to understand, okay, they might get on a stroke unit, but they're in ICU. So I think we need to unpack that information as well.
Yes, I think that's a marvellous demonstration of that once you start, there's nowhere to stop. There's always
Yeah.
something.
You just got to keep getting more students.
Yes. Well, that's
Get more
good.
students, more passion.
We need to train more people in the analysis of this kind of data. I think it's going to be a
I
really
know,
good.
I think, moving forward, I think for the future for data linkage, I really think we need some type of course that's certified to ensure that the people are analysing it correctly. Because it's not the actual analysis that's the easy part, it's that preparation of the data set that's really the complex. Every time you've got a new research question, you need to sit there and manipulate the data to prepare the data to answer that particular research question.
Yeah, sure. So I think we might finish up there. For people who are interested in linkage to registries, we had an earlier webinar about linkage to the ANS data, the transplant registry. So you might like to check out our YouTube channel to have a look at that. Next week, we've got Rachel Moran from Curtin University is going to be talking about the use of linked administrative data to evaluate continuity of primary care. So that's an interesting topic.
I hope you go to that one.
Very topical, everybody primary care. And finally, I just want to remind everybody that the PHRN will be hosting Australia's Data Future Symposium in Sydney on the 21st of November at the Opera House. And to check out our website and go and purchase your ticket, because it should be a fabulous event and we'd love to see you all there. So thank you all. Thank you once again, Monique. That was fabulous. And everybody have a great rest of your day. Thank you.
Thank you. See you.
Thank you.